Dennis?
Great, thank you. In keeping with the theme of this, as one of the blind persons wandering around this elephant, when you divided us up this morning, I actually didn't feel comfortable. My entry point into this discussion, in fact, is infectious diseases, and over the last 15 years, emerging infectious diseases. But after 30 years in this space, I would have actually felt much more comfortable in the middle of the room rather than having been on either side. And there are really four reasons, and I'm going to make 4 points that sort of underscore that personal migration or evolution of my own understanding about infectious diseases and the larger ecology in which it sits. The first, yesterday morning, we heard the discussion about an epidemiologic collision. And I want to pick up on that because in our work on emerging infectious diseases, a lot of it has to do with not trying to address and deal with what we understand to be the current threats. It's also looking at the underlying drivers and trying to project out over the next 50 years what the world's going to look like with all of the different demographic, economic, ecologic changes that are going on, and how those particular challenges are going to play themselves out. So how can we better understand how we position ourselves in a more forward-leaning way? But in the process of looking at that, it was really difficult not to appreciate that the dynamics that were going to potentiate and exacerbate emerging infectious diseases were also contributing to another series of events that was going to lead to populations not only challenged by emerging infectious diseases, but were going to become increasingly challenged by non-communicable. And that was significant for my work because the one thing that we've seen over the last decade, 15 years at least, is emerging diseases. Take influenzas, H5N1 to H7N9, H1N1, or take MERS or SARS. One of the things that we've repeatedly seen is that the populations that are most vulnerable to those infections are populations living with pre-existing conditions, some form of non-communicable disease. You saw it in spades in the H1N1 pandemic at the emergence in Mexico in 2009, where you saw an extraordinary high mortality rate in Mexico that didn't play itself out in the rest of the world, and it was largely associated with a population that is severely obese, and the obesity exacerbated that infection. And so when we look at how those syndemics events play themselves out, I've begun asking, what will that likely mean when we get out to 2050 in places like Africa, where we see economic population settlement dynamics, an emergent middle class, all driven by likely consumerism, that we're going to start seeing the kinds of underlying conditions that will lead towards non-communicable diseases of lifestyle. And a lot of our work on emerging diseases is trying to understand the world in terms of hotspots. Well, there are going to be likely hotspots for these non-communicable diseases. And so as we think about this collision, what does that mean for populations, urbanized populations now with compromised, diabetes or with cardiovascular conditions that are now being exposed to emerging infectious diseases. So it's not possible to really solve the problem of emerging infectious diseases without thinking about non-communicables, if you're looking at this trajectory and thinking about the way forward. And what that means from my side is that if you're thinking about how do you prepare for these events, preparing for an epidemic or preparing for a pandemic, it's not simply about how do we better manage that emergent viral disease. We need to understand the context in which it's going to emerge. And so we really need to have preparedness plans that are taking into account what are the likely population risks for non-communicable and emergent diseases. So part of this country-by-country preparedness exercise we're going through, we would be better informed if we knew where within each of these countries are likely to be these hotspots for both EIDs, but also for non-communicable diseases, and be able to understand what we have to do to better manage or co-manage those events. But the third point is that we really don't know how to do that. We don't have the evidence. We don't have the evidence for being able to talk about non-communicable disease hotspots. And we certainly don't have the evidence of how do we manage those co-conditions. So if we, in fact, have an epidemic of, say, a coronavirus, how do we better manage a coexistent condition of diabetes with someone who has it? We don't have the protocols to be able to do that. So there's a need to develop greater evidence base, both in terms of our understanding about sort of the emergence of non-communicable disease hotspots and their convergence with emerging infectious disease hotspots. All of that then puts us in a position of saying, how do we reorient health systems to not stand on one side of the room or on the other side of the room, but to create a much more integrated approach that when you are dealing with an infectious disease, one of the very first steps in that diagnostic algorithm is understanding if there's an underlying condition that they also have to be dealt with. And if we have a playbook that deals with clear clinical guidelines for how you manage those, co-manage them, then you're in a better position to reduce the impact of these events. So it's, part of it is trying to understand where we're heading, use that information about projections and forecasting, and begin to lay down an evidence base that allows you to really maximize your insights. And then you have to reorient the systems to be much more adaptable to being able to use this information for better management of these events, which will be playing themselves out over the decades to come. So I'll leave it at that.